Welcome to The Explainer. Today, we're going to break down some detailed clinical notes to map out the entire journey of endometrial cancer, right from the very first signs all the way to what the future of treatment looks like. All right, let's kick things off with a pretty fundamental question. When you think about all the cancers of the female reproductive system, which one do you think is actually the most common? And there's your answer, endometrial cancer. That's what we're diving into today. And once this diagnosis is made, it kicks off a really specific, well-trodden clinical path. So where does this all start for a patient? Well, it begins with recognizing those very first signs, the symptoms that make someone pick up the phone and make a doctor's appointment. And if you look at the data, a really clear pattern just pops right out. The median age for diagnosis is 60 years old, and the sweet spot, if you can call it that, is between the ages of 50 and 70. So these are the classic things that bring someone into the clinic. But the big one, the most common and most specific complaint is any bleeding at all after menopause. While, things like pelvic pressure can happen, it's that postmenopausal bleeding that really acts as a huge red flag and gets the whole diagnostic ball rolling. Now, once a patient shows up with these kinds of symptoms, clinicians don't just guess. Nope. They follow a very clear, evidence-based roadmap, an algorithm, to figure out exactly what's going on. First stop on that roadmap, a transvaginal sonography, or TVS. You can just think of this as a special kind of ultrasound. It gives the doctor a really clear view of the uterus, and most importantly, lets them measure the thickness of the uterine lining, which is called the endometrium. And that one measurement, it's a huge fork in the road. If that lining measures 4 millimeters or more, it's an immediate trigger for the next step, an endometrial biopsy. This is how they get a real tissue sample to see definitively if there are any cancer cells there. But if you want the absolute, undisputed best picture of what's going on, the gold standard, that's a hysteroscopy with something called fractional curettage. This lets a doctor actually look inside the uterus with a camera and take very targeted samples. It gives them all the juicy details, like the cancer-specific type, its grade, and its histology. And here it is. This chart from our source notes just lays it all out perfectly. You can literally see the decision tree in action. You start with the TVS, you hit that 4 millimeter cutoff, and it points you right to a biopsy, and then maybe on to the more detailed hysteroscopy. It's just a super logical and efficient path to a solid diagnosis. Now, depending on what those first tests find, they might need to bring in the heavy hitters, the more advanced imaging. An MRI is the best tool to see if the cancer has grown into the muscle wall of the uterus. A CT scan is great for checking if it's spread to the omentum, and a PET-CT is what you use to get the best look at the lymph nodes. Okay, diagnosis is confirmed. Now comes the next critical phase, staging. And this is all about answering one simple but huge question. How far has the cancer spread? To do that, they use a globally recognized system called FIGO Staging. It's basically a map of the cancer's location. Stage 1 means it's totally contained inside the uterus. Stage 2 means it's reached the cervix. Stage 3 means it's gotten outside the uterus but is still hanging around the pelvis, like in the ovaries or nearby lymph nodes. And then you have Stage 4, the most advanced, where it's spread to other organs like the bladder or the bowel. But here's where things get really, really interesting. Staging isn't static, it's evolving in a major way. The traditional system was all about what surgeons could see and what pathologists found under a microscope. But the brand new 2023 guidelines add this whole other layer, molecular classification. And folks, this is an absolute game changer. We're now looking at the tumor's actual genetics, which tells us so much more about how it's going to behave. So you take all of that information, the diagnosis, the stage, and now this incredible molecular profile, and it all funnels into creating the treatment plan. It's a strategy for the surgery itself and for everything that comes after. Surgery is really the cornerstone of treatment, and the type of operation is tied directly to the stage. For an early stage 1 cancer, the standard is a TH plus BSO. That's a total abdominal hysterectomy plus removing both fallopian tubes and ovaries. As the cancer gets more advanced, the surgeries get more extensive, like a Wertheim hysterectomy, all the way to what's called debulking surgery for stage 4, where the goal is just to remove as much of the tumor as physically possible. But the journey doesn't just stop after surgery. What comes next all depends on the patient's risk profile. For low-risk patients, think very early stage, low-grade cancer. They might not need any more treatment at all. Those at intermediate risk usually get radiotherapy, while high-risk patients often need a 1-2 punch of both chemotherapy and radiotherapy. All right, let's wrap up by looking ahead, First, at the things that really shape a patient's long-term outcome, and second, how we can actually approach prevention for people we know are at a higher risk. And remember that molecular classification we talked about? This is where it becomes so incredibly powerful for predicting what's going to happen. The specific genetics of a tumor can point to a really good or a really bad prognosis. For instance, a tumor with what's called a POL mutation, that's actually linked to a very good outcome. On the flip side, an abnormality in a gene called P53 suggests a much more aggressive cancer. This is a level of detail we just never had before. So, what about prevention? Well, for the general population, there isn't a universal screening test. But for folks with known hereditary cancer syndromes, like Lynch syndrome, the advice is totally different. For them, the recommendation is clear. Start getting annual endometrial biopsies at age 35. And for these high-risk women, the single most effective form of prevention is actually prophylactic surgery. The idea is, once they're done having children, a total hysterectomy with removal of the ovaries and fallopian tubes is recommended around age 40. It's kind of like a two-for-one deal. The hysterectomy prevents endometrial cancer, and taking out the ovaries prevents ovarian cancer. And all of this leaves us with a really fascinating final thought. We are literally standing on the edge of a new era. As this deep molecular profiling goes from being experimental to just standard practice, how is knowing a tumor's unique genetic fingerprint from day one going to completely reshape a patient's entire treatment journey? The future isn't just personalized, it's here.